This recording is intended for attendees of TFIM 2025 and those who purchased event recordings only. Recordings are not to be shared or otherwise posted or published. Any use other than for personal learning is strictly prohibited. The views expressed by the speaker are their own and may not reflect those of the TFIM organization.
Okay, it is my pleasure to introduce Kat Toups. She's a functional medicine psychiatrist and researcher using multimodal approaches to treat cognitive impairment and dementia, combining the best of precision, functional, and regenerative medicine. She's board certified by the American Board of Psychiatry and Neurology. She's a distinguished fellow of the American Psychiatric Association and a certified practitioner with the Institute for Functional Medicine. She's been the principal investigator on over 100 clinical research trials. Her specialty is reversing dementia, and she's recently collaborated with Dr. Dale Bredesen, who all of you know with his wonderful work on reversing Alzheimer's disease. And she collaborated with him on a prospective clinical trial using a functional medicine approach to reverse mild cognitive impairment and early dementia. In that study, 84% of the patients had improvement, including their MRI scans. This paper was published in the prestigious Journal of Alzheimer's Disease in July 2022, and 2 additional papers are out. Her talk today is Dementia Demystified, Practical Applications for Reversing Cognitive Decline with Precision Medicine. And please welcome Kat Toups to the stage. Thank you.
Well, hello, everybody. Thanks for hanging in here at the end of the day. And I'm going to apologize in advance. I have so much to cover that I'm going to be speaking really quickly, but I have a lot of detail in my slides. And if you go to the end of the slides, I have quite a few slides on resources that will tell you where can you test this, where can you get this. So hopefully that will help you, that you won't have to take so many notes. Let's get started, and I think I already passed one up. Okay, so I have 2 important messages that I really want you to take away from this talk, that dementia is both preventable and treatable when we can find and correct the underlying causes of the dementia. And it's just important for everybody to know that dementia does not have to be a death sentence. That's the terrifying thing about this disorder, because historically it has been a death sentence, but we've learned so much. And so in one short hour, I'm going to try to teach you what I've learned from the functional precision medicine world in the last 15 years. There's 2 clinical trials now that I've worked on with Dale Bredesen. I'm the principal investigator and have an extensive research history, as you heard. But I'm going to tell you about the first study that we did complete and has been published. We have 3 papers for that, and those are listed at the end of the slides. And then we have another study we're almost finished with our current study. We have 75% of the patients that have completed, and that study is a randomized clinical trial. So we have 2 different treatment groups, 2/3 of the people getting active treatment with a precision medicine approach, and 1/3 asked to not have any treatment, and then we give them treatment at the end of the study. So if any of you are going to IFM, I'll actually be presenting the interim data from that study there. But I'm going to tell you about the one that we just did. And then some more about what's involved with all this. So the first study, we call it the 4 Winds clinical trial. Our sponsor was, that's one of her associations. This trial had 25 patients. Patients had mild cognitive impairment and early dementia. We tested for the cognitive measures using the MoCA and CNS vital signs. CNS vital signs is a really elegant online battery, neuropsych battery that takes about 45 minutes. It's inexpensive, it's easy to do, it's been well validated in many studies. And so patients had to meet criteria for either MCI or early dementia with the CNS vital signs, and the MoCA scores, they had to be over 18. So below 18, you're starting to get into moderate dementia. I worked with 2 other wonderful investigators, Anne Hathaway and Deborah Gordon, and of course, Dale Bredesen was our main advisor. It was a 9-month trial, and so I'll show you what you can do in 9 months if you work aggressively. All of the patients did have an active treatment plan using precision medicine, functional medicine. We repeated the cognitive testing every 3 months, and we also had each patient had to have a study partner. They weren't really a caregiver because at this phase of MCI or early dementia, they're not really needing caretaking full time, but we had to have somebody living with them that could give us some independent verification of how they were doing. We also did MRI studies using volumetric imaging with NeuroQuant at the beginning and the end of the study, and I'll show you some of those results. Okay, let me make sure that's the next slide. Okay, yes. So what did we do in this trial? Well, we focused on a diet. We had people doing a ketogenic diet, and I'll say some more about that in a little while, with at least mild ketosis. One thing I will tell you that we've learned over time is the further people get into ketosis, sometimes they'll do more better. So it's an interesting thing to help people kind of try to deepen that and see if their cognition improves further. We asked people to eat a grain-free diet, gluten-free, dairy-free, grain-free, whole foods, organic foods, lots of vegetables, lots of healthy fats, and then small amounts of animal protein, free range. We had them do time-restricted feeding, time-restricted eating, time-restricted feeding, and restricting their calories to 8 to 12 hours of the day. Initially, people would start at 12, and then as they became better metabolically adapted and more metabolically flexible, they would reduce their time more and more. We asked them, if possible, to avoid eating 2 or 3 hours before bedtime so that the digestion could be completed and not impact their sleep. We worked on sleep optimization. Everyone was tested for sleep apnea, and when we looked at other factors with their sleep, exercise is critical for general health, of course, in regenerating your brain. And we had people do a combination of strength and balance training, aerobic training, and high-intensity interval training. We used brain training for some of the neuroregeneration and neuroplasticity. We had people use the Brain HQ program, and that's been used in a lot of studies, and we're actually able to track that directly to see how our patients are doing in the study. We incorporated mindfulness or stress reduction, important for any kind of healing, right? You have to be able to get into a parasympathetic mode so that things can regenerate. And we used heart math for that, and we're using that again. I love heart math just because it's so simple and elegant. They have beautiful data that it works, but even children can learn to do it. We also focused on the dental health, and I'll say more about that. But we've, of course, learned that what's happening in the mouth tracks right up into the brain. And so we were given donations from the Biocidin people with dental site and toothpaste and mouth rinse. And we had our people doing that to help their oral hygiene. We had a dream team in this study and with our current study as well. And I feel like, one of the big things I took away from my first study is how important it is to have this support team when you're trying to help somebody reverse cognitive decline, because it does kind of take a village. So each patient had a nutritionist, a health coach, and an exercise coach. And then, of course, they had their study partner. This is some of the testing that we did, and I have some more slides on testing as well, but we did a large battery of tests. We looked at nutrients, omega fatty acids, and metals on the Genova NutrIval. We did a whole battery of cardiometabolic, inflammatory, immune markers, hormones. We tested all the hormones, infections. I'll give you some more examples of all the things that we test, including tick-borne illness. Dr. Schwartzbach from Armin Labs actually donated the testing for that study, and we were able to use that for some of our tick-borne testing. Mycotoxins, chemical toxins, organic acids. We used home mold testing. If it was indicated, we did Marcon's nasal testing, not for everybody, but when indicated, comprehensive stool analysis. And each patient has had amazing genetic testing from Intellex DNA. And I'll show you some of the things that we looked at with that. So what did we do for the treatment beyond all those basics? We used some basic nutrients for nutritional and mitochondrial support, and maybe sometimes nootropic support. All the hormone levels were optimized. And beyond that, every patient's treatment was individualized. So it depended on what factors they brought to the table. So we didn't have a set protocol beyond that. But let's just cut to the results. As Neil alluded to, in this study, 84% of our patients got better, and 4% had no change and 12% declined. So that right there was just pretty earth-shattering compared to what we're seeing with all the pharmaceutical trials right there. And here's a look at some of our data. So the MoCA is a battery similar to the Many Mental Status Exam, but it's more geared toward earlier in cognitive decline, so MCI and early Alzheimer's. And you can see that at each data point, people already at 3 months had a clinically relevant separation in their MoCA, and it continued over the 9 months of the trial. And then the CNS vital signs is that neuropsych battery, and that's the overall score on CNS vital signs. And again, you can see that it trended upward all the way through. And actually, one of our investigators in our current study, who's here today, Christine Burke, was just telling me that in her study right now, one of her patients finished with a MoCA of 26, and they just retested him 3 months after he finished, and it's still going up, and he was up to a 29. The top score on that is 30, but anything above 26 is considered normal. This is a slide that Dale Bredesen made showing some comparisons to some of the current anti-amyloid drugs compared to the results that we had in our trial. With the anti-amyloid drugs, people don't get better. They just decline a little more slowly. They might slow down the decline for 4 to 8 months, but they don't get better. So you can see that what we do has quite different results. And this was an amazing shocker for us, the brain MRI volumetric changes. We didn't really expect to see anything in 9 months on MRI changes. That's not a lot of time. But what happens, even with normal aging over 1 year in this age cohort, you will have decreases in your gray matter and your hippocampal volumes. It's just considered inevitable. That's what happens. Now, if you have MCI or Alzheimer's, you're going to decline much more rapidly. But what we saw in our study was that our patients actually increased their gray matter volume. And then, normal controls decreased and Alzheimer's patients decreased some more. So this was pretty shocking and exciting to us. Their hippocampal volumes did decrease, but you can see the numbers here. They decreased much less than normal controls, and certainly much less than people that were diagnosed with MCI or Alzheimer's, which these people were. We had other side effects of our study, but they were mostly improvements. Improvements in people, their weight circumference, their BMI, their strength, their fitness, their blood pressure, their lipids, their glucose levels, their inflammatory levels, and their immune levels. So let's get into some of the nitty-gritty of, what is a little of dementia, and again, some more specifics on what we do with this approach. So I'll note that I often use Alzheimer's and dementia interchangeably. Alzheimer's is a type of dementia. It's the most common type of dementia, but they're all neurodegenerative disorders. And these kind of approaches are worthwhile trying for any kind of neurodegenerative disorder. Some of them, various types of dementia have different specifics, and some of them will respond better to this than others, and not everyone will get better. I would never promise that anything works for anyone, but this is an approach that's worth trying because we've seen success with other kinds of dementias as well. So Alzheimer's disease is a neurodegenerative disorder, but I want people to understand it's not just this mysterious, untreatable brain disorder. It happens for reasons. So it's a reversible multi-system illness, and it happens from toxins and infections and inflammation and lack of hormones and other diet and lifestyle factors, and it can also have a strong immune component for some people. So there's reasons that all these things happen, and our job becomes to identify and search out all of these reasons. And then when we can address those things, then we can get traction for stopping the decline and hopefully reversing the degenerative process if it's not too late. So Alzheimer's is a multifactorial disease. You can see some of the contributing factors here, and I've pretty much just named them all. I won't read them all off, but I guess some of the things that I didn't mention, chronic stress and depression can cause dementia, obviously head trauma and lack of hormones, which I'll say more about. And then once we can find the factors, remove the factors, replace what's needed, we can also, while we're doing this, employ neuroplasticity, which is, of course, the amazing capacity that our brain has to regenerate. When I did my psychiatry training now many decades ago, we were taught that when you were 18, you had all the neurons that you were ever going to get, and that was it. And it was going to be downhill from there. And that was so wrong, it turns out, thankfully. There was a study, I wish I could find it because it was from 20 years ago, but they put people into scanners like just at, they were near the time of their death. Older people that were, about to die, and they gave them learning tasks to do. And they were able to show with the scans that they were able to make new synaptic connections, even in old age at the time of death. So this is an exciting thing that has to be factored in for people. So we use functional medicine or precision medicine. They're almost interchangeable. Functional medicine wants to look at the root causes of illness, and it asks why. Why does this person have this disease, and what has caused it? And precision medicine is personalized medicine, and they look for the right treatments for the right patient at the right time. So I think both of them are individualized modalities, and to me, they're pretty interchangeable. So this approach, like everything we do in functional medicine, is not a pill for an ill. I, again, was trained in traditional psychiatry and neurology, and we were taught to diagnose something and give a pill for it. And the longer I did it, and I did over 100 clinical trials with all kinds of new medication, and I would get so excited with every new mechanism of action, thinking, okay, this is going to help my patients with depression that didn't get better, or this is going to help my patients with schizophrenia. But I saw that sometimes the medicines relieved some suffering, but they didn't get people well. So my goal, and as a functional medicine physician, is how do I get people well? And so with a multifactorial illness like Alzheimer's, there's just not going to be any one pill that gets people well. It's going to take rolling up your sleeves. And in what I advocate doing, it's not easy to do, but when you get your brain back and you get your life back, it ends up being worth it. So the anti-amyloid drugs that have come out in the last couple of years, as I mentioned, they don't stop the cognitive decline. And so it's just important, especially for anybody working in mental health, to understand that the brain is not separate from the body. That's how I was taught, but it's not true. And so whatever's happening in your body is happening in your brain. So it's important for us to learn about and look at all those things. Okay, so what happens when somebody starts having some cognitive issues? It's called senior moments. Word finding difficulty is one of the first things I find that a lot of people have, and they're just can't get the word out. Or when it gets a little worse, you say the wrong word. You can forget people's names. You can start dropping the ball on things that you used to be on top of. You can forget details of events. And when it's really bad, you forget what you did yesterday. Misplacing or losing things, trouble with directions, and over-reliance on GPS. I live in the San Francisco Bay Area, and we rely on GPS a lot. But if you have to use it to get places that you really know how to get to, maybe that's a little clue. Sometimes people will start having trouble with math, like they could calculate a tip in their head, and they just can't get their brain to do it anymore. And following recipes is an interesting thing for people that like to cook, and whether they're following a recipe in a book or they know how to do it in their head. Cooking is a very complex higher function. There's a lot of executive function planning that's needed to go with cooking to get everything to come together at the right time. So you'll see people stop cooking so much and just getting overwhelmed with things. So what happens when you have these senior moments? You get a little worried and you say, okay, I better go to my doctor and see what the doctor has to say. And typically you're patted on the back and said, oh, don't worry, everybody has some changes with aging and there's nothing to worry about. But I'm telling you, this is wrong. If you think you have a problem, if your patient thinks they have a problem, pay attention to that, because we call it now SCI, or subjective cognitive impairment. It can start even decades before people start manifesting MCI or dementia. And I want to just show you some statistics on one of my patients in the first study. This patient was, he was in his mid-60s, maybe early 60s. He was a physician, surgical subspecialist, an inventor, highly educated, very smart guy. And he started having some problems, and he went to his doctor at Kaiser in 2016 complaining of memory problems, and they tested him. And they said, oh, gee, that's the ones here on the left. They said, you know, it's not bad. Your only score that's bad is your delayed memory. Well, that delayed memory was in the 18th percentile. So in a neurocognitive test, 50 percentile is average. So that's going to be average person, average IQ. This is somebody that's highly educated, and you know, he should have been testing at much higher levels than 50%. But they told him not to worry. They said, eat right, sleep right, take care of yourself. So what did he do? Nothing. I mean, they told him he was okay, so he didn't do anything. And 3 years later, he qualified to be in my clinical trial. And at that point, his verbal memory, which is probably similar to their delayed memory, had now tanked down to the 7th percentile, which is very bad. And his composite memory, which is overall verbal and visual memory, was in the 21st percentile. But here's the good news. By the end of the 9-month trial, his verbal memory was at the 92nd percentile. So you can see he was going down, but we caught it in time, and he got back up where he should be. So Alzheimer's is, it's a neurodegenerative disorder that's typically characterized by amyloid plaques or neurofibrillary tangles. The plaques are called, sometimes called A beta for amyloid beta, and the tangles are called tau beta, or just tau for short. And again, the amyloid hypothesis has been with the pharmaceutical industry that we're getting these amyloid plaques, they're gumming up the works of the brain, and that should be what we need to treat to get rid of this. But as I've showed you, that doesn't work with the anti-amyloid drugs. They can slow things down a little, but they don't get people better. And this is because the amyloid secretion is a downstream effect. So we need to go upstream to figure out what's causing it to be secreted in the first place. So amyloid is this sticky, gooey substance, and it gets secreted around the neurons in the brain to protect them from damage. So whenever there's a threat or any kind of hostile provocation in your brain, the amyloid comes to be just like you make a scab when you're bleeding to protect the wound. Well, that's what the amyloid's trying to do in the brain, and it can be an infection in the brain, it can be toxins in the brain, it can be an immune disorder causing neuroinflammation. So what we want to do is figure out, you know, again, what's causing these attacks on the brain, rather than just trying to remove the amyloid. Now, maybe removing the amyloid could be useful later after we get rid of all the things that are causing this, but just removing it doesn't work. And of course, we've also seen up to 24% risk of brain bleeds and brain hemorrhaging from the anti-amyloid drugs, so they are not without risk. There are certain genes, I'll say a little bit about genetics, but certain genes that lead to a more exuberant amyloid response. So all of us will make amyloid with a provocation, but if you have these 3 genes, ApoE4, presenilin-1, an amyloid precursor protein, you will have more amyloid secreted than somebody without it. Those last 2 are genes that are involved with early Alzheimer's. And ApoE4, I think I have some more on that, but it's about 24% of the population has that. But the important thing to know, first off, is genes don't equal destiny. So we have people with, you know, 2 copies of E4 that does confer a very high risk of Alzheimer's that are doing fine. And so what we want to work with is the epigenetic factors that we know about now that can turn on or off those genes to prevent the problem from happening. But if you have E4, because you're going to have a more exuberant amyloid response, you need to work harder. And if you have 2 copies of E4, you should be working early on with prevention. There's so many interesting things coming out with the genetics. We're way beyond ApoE4 here. I learned a lot of this from Sharon Hausman-Cohen, who's the head of Intellex DNA, and we've used their panels in both of our studies. And these are some of the mitigating factors. I won't read this all to you, but you can look at it later. But you know, some of them will significantly increase your Alzheimer risk. Some of them will almost negate your Alzheimer risk. So the second one, if you don't have TOM40 or ApoC1, even if you have an E4, you're going to have much, much lower risk of Alzheimer's. There's one I want to mention, the one that the last 3 rows, the BCHK variant. So that variant can increase or decrease your Alzheimer risk. But a really fascinating thing to me is if you have that variant and you are prescribed a cholinesterase inhibitor like Aricept for dementia, that will hasten your cognitive decline. So some people can take Aricept and it'll slow down the decline for about a year. It doesn't seem to work forever, but some people do get, some improvement or certainly some, slower decline. I did all those early studies with all those earlier Alzheimer drugs. So, I saw that in action. But if you have this variant, you will actually decrease faster. And it's tough because not too many people know about that, and it's not easy to get that test. I really haven't found anywhere else than doing the whole panel on Intellex DNA. So if anybody finds a place to test that, please let me know. Okay, so how do you think about putting some of this together? Well, I think about the 3 R's. We learned the 4 or 5 R's in functional medicine, but for the purposes of this, I want to remove the factors that are weakening or hurting the body and brain. I want to replace the nutrients and the hormones that are needed, and then I want to regenerate the brain to help regrow those damaged neuronal connections. So let's talk about some of the remove. A lot of this is being covered at this conference. Infections, toxins, mycotoxins, metals, high blood sugar, high lipids, inflammation, immune problems. These are 13 modifiable risk factors. This is just from traditional, medicine, looking at what are some things that people can change. Midlife hearing loss is the most modifiable risk factor for dementia. So I really do advocate that everybody get a baseline hearing test by 50 and follow that. Education, traumatic brain injury, hypertension, physical inactivity, diabetes, gum disease, alcohol, obesity, smoking, depression, social contact or lack thereof, and air pollution. These are all things that people can work with. With the testing, when you have dementia, there's no time to lose. You can't test a few things and then test a few more, and it might take you a year to get all this testing done. People can lose so much ground in that time. So in this case, I really do advocate just casting a wide net, testing everything up front. I'll get all the testing. I'll work out what are their target factors. And, then I may have to figure out what am I going to treat first, because sometimes you can't treat it all at once, but at least you know what you're dealing with. And so these are some of the things that we test. I think one thing I didn't mention in the other ones was clotting factors, the vascular factors in vascular dementia are a huge factor here. So the HPA axis is the hypothalamus pituitary adrenal axis, and some people also include the thyroid in that axis. And that's, starting in your brain and your hypothalamus and your pituitary, and that control and the feedback loops there get disrupted. And so any of these things can disrupt this: infections, mycotoxins, head trauma, chemical toxins, heavy metals, and lack of hormones. Now, these are some, and not all. I have 2 long pages of infections that I found multiple studies on each one that show that they can impact the brain. But these are some of the biggies that I test for up front in everybody here. I won't read them all, but you'll have them so that you can go through this. And of course, a couple years ago, I had to add COVID to this list because we've all seen now what COVID can do with cognitive decline. I use a term, and I was tickled to see that Dr. Schwartzbach's talk tomorrow it's called I cubed, because that's what I've always done with my dementia work. So that's infection, inflammation, and immune. Those are 3 big things that I'm thinking about in all these patients. And when you have immune activation, it releases inflammatory cytokines to fight infections generally, or it can be from a toxin. These inflammatory cytokines then cause the deposition of the amyloid plaques to protect those neurons. And as I'm not sure that I mentioned it, but a little amyloid is protective. It's great. But when you have a chronic infection or chronic infections plural, and you're building up that amyloid over time, it's going to start destroying those neurons. And I'm sure most of you have seen this, even in young people with brain-based infections like Lyme disease or mycotoxin illness. We can see cognitive decline, and we can see lack of hormones in those people too. So immune is one of the things that I mentioned, and aging is thought to just innately affect your immune system. You know, people's immune systems decline with age. And so aging and stress can both suppress the immune system. So when the immune system is suppressed, it allows these latent viruses that live in our bodies indefinitely to wake up or reactivate. And some infections like Lyme disease will directly suppress the immune system as well. So we've just got to be cognizant of all these factors. Then the immune system makes the cytokines to kill the invaders. That causes neuroinflammation. The neuroinflammation starts destroying our brain cells. So we just can't say it enough. We need to find all these things that are triggering the immune system, including food allergies for some people. Here's an interesting thing about viruses, a couple of papers there for your reference that were telling us about the herpes viruses and the HHV6A and HH7 and then HSV1 a paper that showed that they clearly accelerate the amyloid deposition as well as the tau fibrillization. They're called tau neurofibrillary tangles. So they're things that get tangled in the fibrils there. But that is accelerated clearly by these herpes viruses. And then progression of the Alzheimer's correlated with increased levels of these viruses in multiple regions of the brain. And here's an exciting thing, a third paper, that when herpes HSV1 and 2 patients were treated with antiviral medications, the relative risk of dementia was decreased by a factor of 10. Like that's a pretty significant finding. So we definitely incorporate active treatment of these viruses in our protocols. And the one thing that we don't really know is, like I use valacyclovir in my patients that have elevated titers of HSV1 and 2, how long to treat them. We don't know that. And there was a study, let's see, that was starting right when COVID hit out of Colombia, and they were treating people with Alzheimer's for 18 months with valacyclovir. That study was never published that I can find. I think it probably died with COVID. And then there was a study at Stanford looking at antivirals for chronic fatigue syndrome. They were using valganciclovir, and they were also using for 18 months. I never could figure out where they got that 18 months from, and we just don't have any outcome. But I try to at least see the titers coming down. I find I'm treating 6 to 12 months for a lot of my patients. Where to test infections. So all those infections that I showed, other than the tick-borne infections, can be done at Quest and LabCorp. The Quest and LabCorp don't have reliable tests for the tick-borne infections. I think a lot of people here know that, but they threw out all the bans that were on the Lyme vaccine, and they only test single strains of things that aren't useful, that we live in a global world now, and people travel and they get different strains. So for the tick-borne, I use IGeneX testing. It's covered by Medicare other than the FISH tests. We use InfectoLab for T-cell testing. And as I mentioned, we used Armin Labs as well in the first study. And when we started our second study, we couldn't ship to Germany right then, so we weren't able, but the T-cell testing has become a really important thing for me to understand. When people may no longer be reacting to the infections, when can I stop the treatment? Sometimes I'll use MDL, Western blot testing, for people that can't afford out-of-pocket testing because they take insurance, but they don't test multiple strains, so it's not quite as accurate. Dental infections, if you have gum disease for 10 years, you're 70% more likely to get Alzheimer's. So addressing what's happening in people's oral health is very important from a preventative standpoint and a treatment standpoint. There's also hidden things. I use a cone beam CAT scan, X-ray in all of my cognitive patients, again, because of the importance of what's happening in their mouth for the brain. Certainly if they have root canals that are thought to be diseased just by definition, I will do a cone beam CAT scan. And but even it can diagnose occult caries and cavities that aren't seen on the regular dental exam. I get those read by a dental radiologist. And then we use home dental testing. These are 4 companies that I know of that do this. we're using MyPeriopath in our current study, but I've just got an account with Simply Perio that I'm excited to test out, because in addition to testing all the pathogens, they're testing viruses. So they test EBV, CMV, HSV, and they test Candida as well. So that can be interesting. Nasal infections, whatever's happening in the mouth and the nose, it tracks right up into the brain. It can go through the cribriform plate. That's just a little porous barrier into our brain, and things can travel up the olfactory nerves. And we've all learned about this from COVID, what it did to people's smell. And also for some people, brain fog and dementia. The mycotoxins, we know now that, they are inhaled and they go to the brain, and several mycotoxins are neurotoxic. Ochratoxin has been linked to Alzheimer's and Parkinson's, and aspergillus in the gliotoxin family has been linked to neurologic impairment. So I have resources on testing again at the end of the slides. Lyme disease, I'm going to go even faster. I have so much to cover, I'm sorry. Lyme loves to live in the brain and the nerve roots. It's a spirochete, just like syphilis, and we've known for over a century that syphilis causes dementia, but Lyme has to be taken just as seriously. And so many of my patients that turn out to have Lyme disease on testing have no recollection of being bitten by a tick. Many of them don't own pets. They're not hikers. You can't just say, oh, they have no risk factors. You've got to test it. Co-infections, Babesia, Bartonella also cause a lot of neuropsychiatric systems, and they need to be tested. Chemical toxins and heavy metals, they disrupt the brain. They disrupt the HPA axis. They affect the immune system. They cause cancer, endocrine disruption, neurodegeneration. We know now that infants are born with hundreds of toxic chemicals in their blood from their mother's exposure. And then if you have genetics that make you not so great at detoxification, you're going to accumulate even more. Pollution is a huge factor with dementia, and Mexico City, obviously one of the world's most polluted cities. Even the dogs there have a problem with dementia. And this study was quite chilling. A 2019 study, they did autopsies of people aged 11 months to 40 years of age, so young, even babies, and 99.5% of them had higher levels of amyloid and tau in their brains than were expected. So that's a pretty scary thought. First responders and people living near the ground zero at 9/11, there's huge amounts of toxins there, and they all started manifesting early onset Alzheimer's. Not all, but a lot of them did. And then just remember, anybody that's ApoE4 needs to be more aggressive at dealing with these things. For detox of the metals and chemicals, mercury, I test mercury in all my patients. If I would tell you, if you tested it, I use Quest more than LabCorp, but I get a quantitative mercury so that I get an actual level. If you get, there's a panel they have of metals at Quest, but it'll just say less than 4. Well, you know what? I want to know if it's 3. I want to know if it's 2. You shouldn't have any mercury in your blood. So when I find high levels of mercury, I have my patients avoid all seafood for a number of months. And I put them on liver support like sulforaphane, the broccoli extract. I personally love Avmacol. They have a lot of nice research data showing that it upregulates more than 200 phase 2 liver enzymes. So for many of my patients, just seafood avoidance, the Avmacol, and then if I can get them to do some kind of sauna or sweating, I can get those mercury levels down pretty easily. Very, very rarely do people need more aggressive chelation. The sauna and sweating can detoxify metals, chemicals, and mycotoxins. And I just always remind people, when you're doing sauna and sweating, wipe off the sweat while it's coming out and jump in the shower immediately after, with soap, so that you can wash off the toxins that you've mobilized, because otherwise they'll reabsorb. We use all kinds of binders with certain patients, and certainly with mycotoxins, we'll use more binders. You can do metal chelation with DMSA and EDTA, and occasionally has to be done with higher levels, but most people don't need that. And sometimes, especially with high lead levels, you don't see high lead, at least I don't in California, like I do with the mercury, but people that are detoxing from lead, you can see some rapid improvement in their cognition. Sauna is a really helpful thing for all of us to think about trying to incorporate for ourselves and our patients. Rhonda Patrick from My Fitness did a number of good YouTube videos and the like teaching people about this. But there was a big 2018 study in Finland where it's kind of a way of life, apparently, that a lot of people use saunas regularly there. And they found that people who use the sauna for just 15 minutes a day or more, 4 to 7 times a week, had 66% less Alzheimer's. And that's pretty substantial. And this was a study done in men. It was a long-term study, huge numbers of people. And the people that used it 3 times a week had a 21% lower incidence of Alzheimer's. So it's kind of the more you do, the better. But any of it is good for people. And then regular sauna use has reduced risk of coronary diseases, sudden cardiac death, stroke, hypertension, respiratory diseases, lower CRP levels, and of course the reduced rates of Alzheimer's. So it's kind of like, what's not to love about that? Mycotoxins, some people can clear mycotoxins easily and they're not a problem for everyone, but some people can't, and then they just can stay in the body and they keep triggering the immune system. And as I mentioned, they can track right up to our brain. We test sometimes some of these other neuropeptide levels that are not exclusive to mycotoxins or Lyme or SIRS, but they're still helpful as we kind of try to make a map of what's causing what. And you can get these at Queston, LabCorp, TGF beta-1, MMP9, VEGF, melanocyte stimulating hormone. And then of course we test urine mycotoxin levels as well. You can get those at Mosaic labs or real-time labs. And I had patients, one who was a good friend of mine and a practitioner, unable to talk. She couldn't talk and feed herself. I mean, it was the most, dramatic case of dementia I have ever seen. She would have killed herself, except she couldn't get organized enough to do it. And it was from her moldy home. She had positive mold reports when she bought it. She owned a beautiful home on the water. I mean, lovely. And she said, well, I didn't see any mold. I didn't smell any mold, but I watched it kill her, almost kill her. And when she finally got out of there, got rid of everything and left, it was one of the most amazing recoveries I've ever seen. She went to some kind of retreat center in upstate New York where they ate raw foods and did coffee enemas and all kind of detox. And something like 6 weeks later, her brain was back. And she was on a plane traveling internationally and teaching, which she had been doing before. And this woman was so close to death, it was amazing. So some of the mold stories, it's so hard for people to believe that mycotoxins and mold can do this, but it sure can. These are some of the home tests for mold that you can do with the dust cloth connection. In our current study, we're using Liz Biotech. We used Mycometrics last time. And if you use Mycometrics, they don't give you the exact score on the ERMI and HERTSME, so you have to input things. You can go to this free program, myhousemakesmesick.com, to get those scores that we follow. Okay, let's say a little bit about sleep. Our brains detoxify when we sleep. So we've learned that we have a lymphatic system in our brain called the glymphatics, and that gets activated during deep sleep. So, in our current study, we have people using Ring, and we're looking at how much sleep they're getting in the different phases. But you want to get into, good deep sleep every night. And if you're chronically getting a little less sleep than you should, kind of 8 hours is the benchmark that people say, but say you're getting 6 hours of sleep because you're really busy. Well, that's 14 hours a week less detox, 60 hours a month, and 720 hours a year that you've just cheated your brain out of detox. So don't let people get by on not sleeping enough. Sleep apnea is a huge factor with dementia, as well as it puts a huge strain on the heart and causes congestive heart failure. But the brain and the heart are our highest consumers of oxygen, and they suffer the most. So we test 100% of our patients for sleep apnea. It can occur even if there's no snoring, even if you're a thin woman, so you typically think of somebody that's carrying more of their weight here and maybe a big neck, but it can happen in anyone, just like with Lyme disease. Everybody needs to be tested if they're having cognitive impairment. Some of the thin women will have upper airway restriction syndrome, which is just a floppiness in their airway, and sometimes that can be relieved by dental device, or there's actually a really cool water bottle called REM Plenish, like for REM sleep, REM Plenish, that you suck against a gradient and it strengthens those muscles for that. When I test for sleep apnea, I have a home device and I have a couple options for that in the slide, the resources that you can get and use. But I have people test 3 nights in a row. Sometimes I'll have 2 nights that look fine, and there's 1 night that's really squirrely. And if that happens, I send them for a sleep referral. I'm not going to read this. You can look at it later, but this is all the bulk of the lab testing that I do. It doesn't have on there the brain biomarkers that we're doing now, but I think I have that in another slide. Oh, there it is, brain biomarkers. So this is kind of the latest stuff, very exciting, just come out in the last 2 years or so. And these are some of the main brain biomarkers that we're tracking in our current study: the amyloid levels, the p-tau levels, neurofilament light, and glial fibrillary acidic protein. So stay tuned for more on that. We're learning about them and what they do. And p-tau has been a little quirky because when people lose a lot of weight, which they sometimes do on a ketogenic diet, it will go up, even though they're cognitively getting better. So there's things that we're learning, and there's some brand new p-taus just come out in the news the last couple of weeks that are supposed to be even better. Oh, and I would say you can get those brain biomarkers at Quest and LabCorp now, but we use a company called Neurocode. They have a different platform that they use, and it's more sensitive and more specific. So I know, I think it was Christine Berg who I mentioned, her patient's still improving. She had a patient she tested before the study at Quest, I think it was, or LabCorp, and their p-tau was normal. And then, but she knew they had cognitive problems, and she tested it at Neurocode, and it came back positive. Okay, micronutrient metal testing, the Genova NutriVal's just a brilliant test for being able to get a lot of things done at once there. If you have proper diagnosis codes, then you could get it covered by Medicare. Quest has some panels of antioxidants, B vitamins, minerals, heavy metals, and LabCorp has a couple of panels as well. This is an example of a volumetric MRI, and this is a report that we get called the triage brain atrophy. Now they've changed it and they look a little bit different than this now, but it gives you the idea that when we do the MRI, you have to order the neuroquant at the same time. It can't be done later because they take additional slices when they're acquiring the MRI. And it's an AI software program that they upload the information to. And it gives us a volume for every structure in the brain compared to an age-matched control. So if we see things in the red, there are 2 standard deviations or more below the mean, so they have degenerated. If we see them in the blue, there are 2 standard deviations or more above the mean, and that means they're inflamed. Those are sources of inflammation. Sometimes with mycotoxins, we'll see certain structures in the blue, but we can see the red get better and the blue get better when we find the right ways to treat people. Okay, what do I have? 7 minutes left. So we want to replace everything that's missing. We want to remove the bad stuff, and we want to replace stuff. It's important to measure all those nutrients and hormone levels, and I'll say more about the hormones in a second. Optimize all the things and the brain inputs, the vision, hearing, and smell. Fortify the immune system. This is basic health that most of you guys know. Eat well, sleep well, exercise, reduce stress, regulate your blood sugar, reduce your toxins, lots of healthy fats for the brain, which is mostly fat. And I also tend to use a lot of LDN as needed for immune support. Detox needs to be a lifelong endeavor. You don't just do it and you're done. The world has just become increasingly toxic. And so I feel like having people incorporate detoxification as a daily practice is important. These are some of the nutrient deficiencies that this can increase dementia risk. I suspect most of you are testing for most of those, but just be aware of that. I kind of use just core supplements, fish oil, B complex, and vitamin D on everybody. Some people need some extra B12. Some people need some methylfolate if they have homozygous MTHFR. And then beyond that, I go for mitochondrial support. So any kind of degenerative process, including aging in general, is killing your mitochondria. And so personally, I use a lot of mitochondrial support with cognitive decline. And amyloid is inhibiting the electron transport chain in the mitochondria. So another reason you want to do it, I like CoQ10, acetyl L-carnitine, NAC, glutathione, or lipoic. And I have some of those listed here. PQQ, vitamin K, shilajit, those are some additional mitochondrial nutrients that I'll use. Hormones in the brain, can't say enough about this. Hormones are neuroprotective, so they're trophic. They just sustain the life of the brain cells. They're neurosteroids made in the brain, and they're neurotransmitters giving signals to different parts of the body. You have receptors for all of these hormones on this slide in your brain. Men and women have estrogen. Men and women have testosterone, pregnenolone, DHEA, thyroid, vitamin D and B12 are actually hormones. They're messengers to different parts of your body. The cannabinoid receptors and brain-derived neurotrophic factor. So these hormones are so important to the brain that the brain makes their own supply of many of them. The hypothalamic neurons make estrogen, and estrogen is a neurotransmitter in the brain. It influences emotions, mood, and cognitive function. It also, interestingly, increases the oxygen perfusion in the brain. It binds the endothelial receptors, and it stimulates nitric oxide release to vasodilate and help the blood flow. And blood flow is critical. And having people exercise helps that blood flow. Estrogen shuttles glucose into the brain. And one of the reasons we use ketogenic diets is that with aging, a lot of people lose the metabolic flexibility to utilize glucose as a fuel. And so when we put them into ketosis, they can utilize the ketones as a fuel instead. But with aging, people are losing their estrogen. Men and women, testosterone in men turns into estrogen, and men with aging lose their testosterone just a little later than women lose their estrogen. So there are certain areas of the brain that estrogen binds that you can see here, important for consolidation of memories, and it's produced in the brain even after menopause or andropause. So this was a cool study that Natalie Razgon did at Stanford a while ago, and they took women who had high risk for Alzheimer's that had been on HRT at least 10 years, and they randomized them to stay on the hormones or stop them, and they followed them for 2 years. And basically, at the end of those 2 years, 100% of the women who stopped their hormones had cognitive decline. They could see it on the FDG PET scans, and they could see it in some of the neurocognitive testing. But the women who stayed on their hormones had preservation. So I'm a big believer of hormones and getting these all right at any age. There's a lot of gynecologists that are taught that if you've been off of hormones 10 or more years, that they somehow become dangerous for you. Well, the old synthetic hormones, Premarin, Provera, yes, those increase inflammation. They go through the liver. Or no oral estrogen for anyone, please, because it's going to increase your risk of stroke and heart attack and PEs. But the bioidenticals are not having those risks. Progesterone is a neurosteroid, really cool one, because it's involved with myelin, production of the myelin sheaths around the nerves, and neuroprotection, also synthesized in the brain and then peripherally in the ovaries and the adrenals. And it can convert into allopregnenolone, which binds GABA, which turns into GABA, which helps sleep and anxiety. But progesterone, there's some nice data on TBI. I didn't see it, Neil. How many minutes do I have? I missed what you were showing. 5. So progesterone, there's nice data after ischemic stroke. If you give it right away, within the first few days, there's decreased mortality and better cognitive recovery. Testosterone, another cool hormone, it boosts dopamine, which is our feel-good hormone, and it helps sleep and depression and motivation. And it's not just for sexual functioning, it helps so many other things, but it really can help cognitively, just like all of these hormones do. It gives cardiovascular protection, protects bone density, maintains lean muscle mass. So I basically replace testosterone in men and women. There are some older women that are still making enough testosterone. So, you got to test people and decide if they need it. For women, I get a compounded, Belmar makes testosterone vaginal tablets that are quite easy to use. You just pop one in at night and it's pretty good. So hormones are trophic for the brain. They just need it to function and to heal for things. And the bottom line shows you, I'll test estrogen, progesterone, free and total testosterone, pregnenolone, DHEAS, the thyroid hormones. I'll also test sex hormone binding globulin, estrone, but those are the key ones that I'm replacing. I call it geriatric HRT. I'm trying to get my GYN friends to do more talks on this, which they are, but we need to have geriatric HRT become a thing and acceptable, because it's such a huge benefit for people. Want to optimize the blood sugar and lipids. Metabolic factors are long known to be destructive to the brain, and anything that's good for the heart is good for the brain. But we've got to control all of these metabolic factors. We've long called dementia type 3 diabetes, but regulating all that is important. Cholesterol, not the enemy. You need to maintain cholesterol levels. It's a precursor to all your hormones, your sex hormones, your thyroid hormones, your stress hormones. And one of my bad cognitive decline patients was on a super dose of statins, and they kept his cholesterol at 130, and it was deadly for his brain. You also need the myelin sheaths that conduct the impulses, are 80% made of lipids. Your white matter is 60% lipids, gray matter 40% lipids. So we need to control some of those advanced lipid markers, but cholesterol is not the enemy. We have people eat lots of healthy fats: coconut, avocado, free-range meat, chicken, fish, wild-caught fish, nuts, and seeds. We had people do the time-restricted eating, which I mentioned, so I won't say it again, the ketogenic diet. Ketogenic diet can be brilliant for people. It does help for them to have support to do it properly. If they can work with nutrition or a health coach to implement it, much better to avoid some of the things. I put everybody on electrolytes to avoid cramping, and we sometimes use exogenous ketones in the beginning to avoid the keto flu, because what happens is people will cut out their carbs, but they won't add enough fats in to sustain their organism. So, but this helps, because I said the brain can't utilize glucose as well with aging, and then that is affecting the mitochondria. So some people don't notice obvious cognitive benefits on a ketogenic diet, but some people, it lights up their brain. It's just pretty amazing. Optimize vision, hearing, and smell. I'll just call your attention to the last thing on here. There's a new study that came out in the last year or two. Just inhaling a pleasant aroma with a diffuser for 2 hours while you're sleeping. And these were in cognitively normal older adults. It increased their verbal memory by 220%. So just get some organic essential oils, put it each night a different one. They rotated some of the smells to stimulate with different things. Exercise is just as important as diet for health and aging. And women who exercise regularly in middle age, considered age 50 in this study, were 90% less likely to develop Alzheimer's. So trying to get our kids to exercise and become exercisers and stay that way is important. High intensity interval training now is very well known for improving metabolic factors quite dramatically. It can improve your mitochondrial levels, lower your blood pressure, improve your blood sugar. And one study showed 30% improvement in memory after just 12 weeks. So important. Sleep and stress, we've kind of talked about some of that, and I think I'm getting close to the end of my slides. Sleep apnea, tracking sleep. Ketogenic diet actually improves slow wave sleep and REM sleep. It's reminding me I want to look at how that worked for my current study data. And heart math for stress reduction, any kind of stress reduction, any kind of mindfulness practice. I tell people you could just, go on a walk in nature and leave your cell phone and smell the smells and listen to the birds and just try to be present. That's mindfulness. We need those moments to get our organism into the parasympathetic tone to regenerate. And then there's neuroplasticity. Exercise and meditation both increase brain-derived neurotrophic factor that helps to make new synaptic connections in your brain. And those are the best validated things. And guess what? They're free. Anybody can do exercise and some kind of meditative or mindfulness thing. new things, exercise, music, and dance are actually have very nice data for making new connections in your brain. I'll tell people like, okay, put on some fun music and dance around the kitchen and just have fun, you know, find little ways to incorporate all these things in. We use heart math, brain HQ for brain training, photobiomodulation, and I just have one more slide. I think it's on the next one. So some promising mitochondrial treatments. We're incorporating, you know, these with various people as possible. Hyperbaric oxygen treatments, photobiomodulation. I actually am doing that in my current study with a device that I love called Origin that's working quite well. Neurofeedback, IV NAD, or you can give NAD sphenocath directly through the nose into the brain. Stem cells and exosomes are showing promise, and plasmapheresis or plasma exchange. So those are some of the new things. And that is it. I'll just point out I have the study papers in here, basic dementia program in a nutshell. Well, that study has, the ship has sailed on that study, and hopefully I'll be reporting that data. It's very exciting. And I'll just end with the final, which is not a death sentence. I hope everybody has seen enough to believe that there are so many factors to mitigate this and change this outcome for people. And then beyond that, I have a lot of resource slides in there. Thank you.